3 times. If you walk a certain way after 60, your risk of having a stroke is 3 times higher than someone your age who walks differently. Not from a pre-existing condition they have and you do not. Not from a medication, from the walk itself. Or, more precisely, from what the walk is telling us about what is happening inside your brain right now, before any other test has flagged it, before any symptom has arrived that you would recognize as serious. I am not talking about a dramatic shuffle or a noticeable limp. I am talking about something subtle enough that every person in your life, and possibly your own doctor, has already written it off as getting older, being careful, or having a sore knee. The problem is that this walk is not a sign of aging. It is a warning. And there is a difference between those two things that I am not willing to let you miss. My name is Dr. Elena Russo. I am an internal medicine physician, and I have been practicing in New Jersey for over 25 years. Most of that career focused on senior care and preventive medicine. I started this channel because I kept watching people receive incomplete explanations, not wrong diagnoses, incomplete pictures. They were told what was happening, but not what it meant. Today, I want to fix that. There is a number, a step count you can measure in your own hallway this evening that will tell you with real clinical weight exactly where you stand. We will get to that number, but first, let me show you what your walk is actually communicating and why almost no one is translating it correctly. The walk I am describing does not look alarming. That is the most important thing I can tell you right up front, because it is the reason this warning gets missed over and over again. Here is what you are looking for. The stride has shortened. Not dramatically. This is not a person dragging their feet. But the distance between one step and the next has gotten smaller over the past year or two. The person takes more steps to cover the same ground. They move a little more slowly, not because they are tired or in pain, but at their natural, comfortable, automatic pace. The stance is slightly wider, feet a little further apart than they used to be. And the arms, one or both, are not swinging the way they did. The arc has shortened. The movement has stiffened. Watch someone walk from the kitchen to the living room, and what you see looks like caution. Like someone being sensible near wet pavement. Like wisdom. Most families see it and think, well, he is 73. Of course he is more careful on his feet. Most primary care physicians, pressed for time at an annual physical, see it and think, arthritis, maybe, or some deconditioning. Let me refer you to physical therapy. The legs are not the problem. The legs are receiving corrupted instructions from a brain under chronic vascular stress. They are doing exactly what they are being told to do. What they are being told to do has changed, and almost nobody is asking why. There is a clinical name for the underlying process driving this pattern. It is called small vessel disease. I am going to give you the full picture of what that means, because once you understand it, everything about this walk will look different to you. But hold that term for now, because the next thing I need to show you is what the research says about where this walk leads. In 2011, a landmark meta-analysis was published in the Journal of the American Medical Association, led by Stephanie Studensky and a research team that pooled data from 9 separate cohort studies involving more than 34,000 community-dwelling older adults. What they found was striking. Gait speed, simply how fast a person walks at their comfortable, natural pace, was one of the most powerful predictors of survival and serious adverse health outcomes in this age group. More predictive in many cases than individual measures like blood pressure or cholesterol alone. The body telegraphs its internal condition through the way it moves. We just have to know what we are reading. Margaret was 67 years old, a retired hospital nurse from Allentown, Pennsylvania. She had spent her career on her feet and was proud of that. When I saw her for a routine cardiovascular visit, she mentioned, almost in passing, that she had been being more careful on her walks lately, taking smaller steps on stairs, hesitating before stepping off curbs. She thought her knees were acting up. Her family thought the same. When I watched her cross the hallway outside my exam room, her gait speed flagged immediately. I ordered a brain MRI. What came back showed white matter changes, early but clear, consistent with small vessel disease in progress. Her blood pressure that day was 148/92. She had been told for 2 years that it was a little high, but not treated as anything urgent. Within a month, she was on medication, and I put her on a structured walking protocol she still follows today. When she came back for her 6-month visit, she said, "I thought I was just being sensible. I had no idea my brain was sending me a warning I had almost ignored." Most people do not know they are ignoring a warning. That is what I want to change today. But here is where it gets even more complicated. The mechanism behind this pattern is not something most cardiologists will bring up at your annual checkup. Understanding it will change how you think about every walk you take from this point forward. Small vessel disease is not a condition most people have heard of. It does not show up on a standard blood panel. It does not produce a dramatic episode that sends you to the emergency room. Not at first. It develops slowly, quietly, over years. And by the time it announces itself through a stroke or a serious fall, it has usually been building for a decade. Here is what it is. Deep inside the brain's white matter, the vast network of long-distance communication cables connecting one region of the brain to another, there are tiny arteries and capillaries, blood vessels far smaller than the ones your cardiologist monitors for blockage. These small vessels are responsible for feeding the white matter continuously with oxygen and glucose. When they are healthy, signals travel through the white matter cleanly and quickly. The motor cortex tells the legs what to do. The cerebellum coordinates balance. The frontal lobe manages the automatic timing of each stride. The whole system works together, below the level of conscious thought, every time you walk across a room. When small vessels begin to fail, that communication system degrades. Not all at once, bit by bit, in small areas, producing what radiologists call white matter lesions, patches of tissue where the blood supply has been compromised long enough that the cells have been damaged. Those patches interrupt the signals. The motor instructions traveling from brain to legs get corrupted in transit. The legs respond to what they receive, which is no longer quite right. Think of small vessel disease like termites in the walls of a house. The front door still opens. The roof is not caving in. From the outside, everything looks intact. But inside the walls, the structure is being eaten away, slowly and invisibly. By the time the wall shows visible damage, the process has been underway for years. What drives small vessel disease? Chronically elevated blood pressure is the single most powerful driver. The mechanical stress of high blood pressure against tiny vessel walls, sustained over years, causes them to thicken, stiffen, and eventually fail to function properly. The medical term for this process is lipohyalinosis, and it is specific to the small vessels of the deep brain. The large arteries your cardiologist monitors are built differently, with more structural resilience. These small ones are not. They are exquisitely sensitive to pressure, and they absorb years of damage long before any scan is ordered to look for it. Insulin resistance, type 2 diabetes, smoking history, and high LDL cholesterol all contribute as independent factors, each damaging vessel walls through different mechanisms, but arriving at the same result: reduced blood flow to the white matter, accumulated lesions, disrupted signaling. And here is what I want you to understand about the aging piece specifically. After 60, the brain's ability to compensate for small vessel damage begins to diminish. A younger brain, faced with a small area of white matter injury, has enough reserve to route signals around the damage, the way a city reroutes traffic around a blocked road. An older brain, particularly one with years of accumulated small lesions, runs out of alternate routes. The symptoms, the gait changes, the cognitive slowing, emerge precisely when that reserve is exhausted, which means by the time the walk changes, the process has usually been underway for a very long time. Most people over 60 with any 2 or 3 of these risk factors have some degree of small vessel disease on imaging, whether they know it or not. Most do not know it because no standard annual checkup is specifically designed to find it. Now here is the connection to stroke that most people never get explained to them. Small vessel disease is an independent, well-documented risk factor for a specific kind of stroke called a lacunar stroke, a stroke that occurs in small, deep brain structures rather than in the large vessels most people associate with the word. Lacunar strokes do not always announce themselves with the dramatic facial drooping and arm weakness of a large vessel stroke. They sometimes present as a brief episode of confusion, a sudden dizziness that passes, a short period of unusual clumsiness. They are frequently dismissed as a funny episode or a dizzy spell. And they are often preceded, for months or years, by the exact gait changes I described at the start of this video. Has a doctor ever pointed out a change in your walk? Or has someone in your family mentioned it and you brushed it off? Write that in the comments. I want to know how many of you have heard those words and what you were told they meant. Now, the question most people have at this point is, how do I know if what I am seeing or what I am experiencing in my own body crosses the line from normal aging into something that needs medical attention this week? There are 4 specific things to look for, and one of them is almost never discussed in a primary care setting. The first is shortened stride length. The distance between one footfall and the next has narrowed compared to where it was a few years ago. Not dramatically, subtly. The person is taking more steps to cross the same kitchen, more steps to reach the mailbox. Most people attribute this to joint pain, because joint pain is the more common explanation that comes to mind, and sometimes it is true. The way to tell the difference: stride shortening from joint disease is usually painful and usually worse on stairs or inclines. Stride shortening from white matter changes tends to be consistent, present on flat surfaces, and painless. The legs do not hurt, they just do not reach as far. The brain has quietly narrowed its instructions, and the body has accepted the adjustment without complaint. The second is reduced or asymmetric arm swing. Walk past a mirror or ask someone to watch you from behind. Are both arms swinging? Is one arm noticeably shorter in its arc than the other, or stiffer, or just hanging without moving? Here's the element most people will never be told. Asymmetric arm swing, one side moving significantly less than the other, is one of the most information-dense signals a walking body produces. On one end of the spectrum, it is associated with early Parkinson's disease, where the dopamine pathways governing automatic motor control are beginning to degrade. On the other end, reduced arm swing on one specific side can indicate carotid artery disease on that same side, affecting motor signals crossing from that hemisphere. Both of these are serious. Both of these are identifiable early, and almost no one outside of a movement disorder clinic or a specialized vascular neurology practice discusses this during a routine primary care visit. It is worth documenting and worth naming explicitly when you see it. The third is slowed automatic pace. Not how fast you walk when you are trying to walk quickly, how fast you walk when you are not thinking about it at all. When you are moving from the bedroom to the bathroom at 6 in the morning, when you are crossing a parking lot without any particular hurry. This is the clinical measure that researchers use, and it is the one I will give you a specific number for in just a moment. I want to note something about this particular sign. People almost never notice it in themselves. They notice it in others. If you are watching someone you love and thinking, "He seems to move a little slower than he used to," trust that observation. Your eye is doing clinical work. The fourth is dual task gait disruption. This one is the most underappreciated and the most telling. Walk down a hallway while counting backward from 20, or while carrying on a conversation about something that requires real thought. Notice what happens. Does your pace slow significantly? Do you stop walking entirely to concentrate? Do you lose your count? Research by Muir, Speechley, and colleagues identified what they called stops walking when talking as a meaningful clinical sign in older adults, associated specifically with white matter disease, with elevated fall risk, and with vascular cognitive impairment. The reason this sign matters so much is what it tells us about the brain's available resources. If the act of walking, which should be entirely automatic, is now consuming enough of the brain's executive capacity that you cannot simultaneously perform a simple cognitive task, something has changed in the underlying circuitry. That is not a normal aging phenomenon. That is a system under strain. And it is a system you can assess in your own hallway today for free. Once you know what you are looking for, the next step is running a simple self-assessment. 4 steps: no equipment, a hallway, and an honest eye. Before I walk you through this, I need to draw a clear line. There are situations where a sudden change in gait is not small vessel disease progressing over months. It is an active stroke in progress right now. If the change in your walking came on suddenly in the last 24 to 48 hours, if it appeared alongside slurred speech, facial drooping, one-sided arm weakness, or sudden confusion, stop this video. Call 911. Do not drive yourself. Do not wait to see if it passes. The protocol I am about to describe is for gradual, chronic changes observed over weeks or months, not for emergencies. Know the difference. It matters more than anything else I will say today. Now, here is what you actually do with this information. Step 1. The 10-meter walk test. Find a straight stretch of floor in your home, a long hallway, a run between two rooms. Measure 10 meters, which is roughly 33 feet, or the length of a typical two-car garage. Walk it at your normal, comfortable, unhurried pace. Time yourself. Under 10 seconds is reassuring for most adults over 60 in reasonable health. Between 10 and 13 seconds warrants monitoring. Tell your physician at your next visit and describe specifically what you have noticed about your walk. Over 13 seconds, do not wait for your next scheduled appointment. Call this week and ask for a gait assessment. These numbers come from the normative gait speed research that informed the Studentsky meta-analysis, and they are used by geriatricians and physical therapists as a first-line screening tool. Most people have never been asked to perform this test because most annual physicals do not include it. You are doing it now. Write down your time, write down the date. You are beginning a clinical record of something that matters. Step 2. The arm swing check. Walk the length of your hallway while someone watches you from behind, or walk past a full-length mirror and watch yourself. Are both arms moving? Is one arm swinging with noticeably less arc than the other, or staying closer to the body, or barely moving at all? Even mild asymmetry, one arm consistently swinging less than the other across multiple passes, is worth documenting and worth naming specifically to your doctor. Do not say, "I feel a little stiff." Say, "My left arm swings significantly less than my right when I walk." Specific language gets specific attention. Vague descriptions get vague responses. Be precise. Step 3. The dual task test. Walk your hallway while counting backward from 20 out loud. Notice what happens. Does your pace slow noticeably? Do you stop walking to concentrate on the count? Do you lose your place? Any of these findings, replicated on more than one attempt, is clinically meaningful and worth raising at your next appointment. When you do raise it, use the exact phrase, "stops walking when talking." That language will communicate instantly to any physician who understands what it means. Step 4. The 30-day observation window. This is not a one-time test. Pick one consistent route in your daily life, from the bedroom to the kitchen, from the front door to the mailbox, from the car to the grocery store entrance. Over the next 4 weeks, notice whether you are taking more steps to cover the same ground, whether you are reaching for walls or counters you did not used to touch, whether you are hesitating at thresholds or curbs you used to cross without thinking. Change over time is the signal, not one bad morning. Every step of this protocol is designed to help you catch small vessel disease before it catches you. The gait change is the warning. The warning is the gift, if you know how to read it. If this is the kind of medicine you have never been given before, subscribe. I make videos like this every week. Raymond was 73 years old, a retired high school principal from Burlington, Vermont. He had spent 30 years managing a building full of teenagers, which he always described as the best cardiovascular training available. He walked every morning. He was not sedentary. He was not a patient you would look at and immediately worry about. His daughter noticed it first. She lived 2 states away and saw him only a few times a year. When she visited for Thanksgiving, she watched him walk from the front door to the kitchen carrying 2 grocery bags and noticed that his left arm was not swinging. It was hanging there, close to his side, barely moving. She mentioned it once, gently. He told her his shoulder had been a little stiff and changed the subject. She did not let it go. She sent him something to read. He came in to see me. When I watched Raymond walk down the hallway outside my exam room, his gait speed measured at 14 seconds over 10 meters. His left arm swing was visibly reduced. When I asked him to count backward from 20 while walking, He stopped completely at the number 12 to finish the count before continuing. He had not noticed any of this. He had been compensating so gradually that the adjustment had become invisible to him. His MRI showed moderate white matter changes throughout the deep periventricular white matter. Not yet in acute stroke territory, but moving toward it with intention. His blood pressure had been treated for years, but running consistently around 145/88, which his previous physician had accepted as adequate control. It was not adequate. We adjusted his medication. I put him on a structured 40-minute walking program, deliberately paced, measured, consistent, focused not on speed, but on stride length and arm movement. He came back 6 months later. His 10-meter walk time was down to 10.5 seconds. His left arm swing had measurably improved. His blood pressure was running 128/76. His daughter sent me a photograph 2 months after that. Raymond on a hiking trail in Vermont with his 2 grandchildren, both arms swinging, moving uphill. He sent a note that said, "I thought she was overreacting. Turns out she was the only one paying attention." Here is what I want you to hold on to from this video. The body signals before the crisis. It does not wait until the stroke to begin communicating. It changes how a person moves, months and sometimes years in advance. Small vessel disease does not appear without warning. It appears with warnings that most people, and most physicians, do not know how to read. Now you know how to read them. Most checkups were not designed to catch this. They were not designed to watch someone walk across a room, measure the arc of their arm swing, or ask them to count backward while moving. That is not a criticism of any individual doctor. It is a structural problem with how annual care is organized for people over 60, where 15 minutes of FaceTime rarely includes the kind of quiet observation that would flag this pattern before it becomes a crisis. That gap is exactly why I make these videos. The information exists. It is well researched. It is not being delivered at scale to the people who need it most. You now know what to look for, in yourself and in the people you love. Tomorrow morning, before you check your phone, before you make coffee, walk from one end of your hallway to the other. Count your steps. Notice your arms. Notice your pace. You just performed a clinical assessment that your last annual physical probably skipped. What you just learned protects your brain from one direction. But there is something quietly working against the same vascular system from a completely different angle. And it happens before most people in this country are fully awake. It has nothing to do with how you move. It has to do with what you put in your body first thing every morning. And the damage it does is happening through the same slow, invisible mechanism we covered today. That video is right there. Watch it next while this is still fresh. If someone you love walks the way I described today, send them this video, right now, before you forget.